Welcome to Clinical Capsules from TRC Healthcare, your go-to podcast for fast, evidence-based insights. On this episode, Associate Editor and Clinical Pharmacist Vickie Danaher examines the use of buprenorphine for treating opioid use disorder, or OUD, in an excerpt from our popular Pharmacy Essential Updates webinar series. TRC has been a trusted resource for healthcare professionals for over 40 years. And now we're bringing that expertise straight to your ears every second and fourth Tuesday in bite-sized, actionable episodes, right here on Clinical Capsules. And new, starting this month, this podcast offers continuing education credit for pharmacist subscribers at our platinum level or higher and pharmacy technician subscribers. Please log in to your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. With that, let's get started.
And we're highlighting this topic today since we as pharmacists and pharmacy technicians play a crucial role in ensuring patients have access to buprenorphine products, such as generic Suboxone, which are first-line treatments for OUD. And we know that in the last few years, there's been some big changes with buprenorphine prescriptions for OUD to help overcome some of the barriers that patients may face with getting treatment. And although many of these changes were initially introduced during the COVID-19 pandemic, they've since been extended and made permanent in some cases. For example, we know that prescribers don't need a special XDEA number to write prescriptions for buprenorphine for OUD anymore. These prescriptions now only require a standard DEA number, so we no longer need to check for an XDEA number on these prescriptions. Also in the past, there was a maximum number of patients that prescribers were allowed to prescribe buprenorphine for. But now there's no limit to the number of patients that prescribers can treat. In addition, federal rules have been expanded to allow prescriptions for buprenorphine to be issued via telehealth or telemedicine under specific regulations. And this may be particularly beneficial for patients in rural or underserved areas who may face barriers to in-person care, such as transportation challenges or financial constraints. But despite these efforts to help expand access, many patients who want or need treatment for opioid use disorder still aren't getting it. And there's many possible reasons for this, but one that relates to us in the pharmacy has to do with medication availability. Recent data indicates that over half of U.S. pharmacies report not having buprenorphine for OUD in stock, which can pose a significant barrier to treatment. Plus, we know when dispensing these prescriptions, questions often pop up about regulations or liability, or there may be concerns about misuse or diversion. So today, we're going to spend a few minutes talking about how we as pharmacists and techs can help extend access to treatment by working together to overcome challenges with dispensing buprenorphine for OUD and understanding how we can best support patients in recovery. A key part of this is also being ready to help new patients starting buprenorphine, because we may be the last stop for that patient before they get started. We want to make every effort to ensure patients have access. This is especially important because patients who can't get buprenorphine products for opioid use disorder are at risk for withdrawal, relapse, or return to use, overdose, and death. Medications to treat OUD also decrease illicit opioid use, reduce criminal activity, improve social functioning, and increase treatment retention. And when we've discussed this topic with experts in the past, they pointed out that patients can change the course of their whole life by starting treatment. And we can help with those efforts. Now, in terms of which buprenorphine products can be used for opioid use disorder, we know that there's combo products with buprenorphine and naloxone, including sublingual tabs or films, or single ingredient products with buprenorphine alone. There's also long-acting buprenorphine injections, which can last up to about a month or so, depending on the product. But these injections will usually be reserved for patients if there's concerns about adherence, abuse, or diversion. They're only available through certified prescribers, must be administered by a healthcare provider, and they cost about $2,000 per month. So, of all these options, anticipate that the combo products with buprenorphine and naloxone are still the go to treatments. Buprenorphine is a partial opioid agonist, which is how it helps prevent withdrawal symptoms. And the naloxone in these sublingual products is an opioid antagonist or blocker, and it's included in an effort to help deter misuse. And that's because when the combos are taken sublingually, naloxone has low bioavailability. But if the combo product is misused by injection, the naloxone may block the effects of buprenorphine or precipitate opioid withdrawal in someone taking opioids. So that's one reason why the combo sublingual tabs or films are generally preferred over sublingual buprenorphine tabs alone. Be aware that any formulation of the combo buprenorphine naloxone products can be used, and the sublingual tabs or films are similarly effective. In terms of dosing, patients may start buprenorphine in a prescriber's office, hospital, or at home, and they'll need to be having withdrawal symptoms before starting to prevent precipitating withdrawal. But after this induction phase, we can recommend titrating to a usual maintenance buprenorphine dose of about 16 to 24 milligrams a day for the sublingual tabs or films. This dose may be more effective than lower doses for preventing illicit opioid use. But the dose does need to be individualized and can vary widely. For example, doses may range from lower doses up to about 24 milligrams per day or more of buprenorphine. And keep in mind that even higher doses may be needed in some cases, such as those with a history of fentanyl misuse or to help manage uncontrolled cravings. Also, be aware that there's no maximum duration of treatment for continuing buprenorphine for OUD. Opioid use disorder is a chronic condition similar to high blood pressure, cardiovascular disease, or diabetes. So just like you wouldn't stop a patient's med after a heart attack or for diabetes, patients with opioid use disorder can also use treatment long term and for as long as they see benefit. And the longer that patients stay on treatment, the lower their risk of illicit use, relapse, and death. So considering that many patients who take buprenorphine products for OUD will be on them long term, and we also want to have buprenorphine available for patients just starting therapy, we'll want to make sure to maintain adequate inventory. So this is a good reminder for us to regularly review our stock levels, anticipate demand to prevent shortages, and collaborate with distributors to ensure a steady supply. Now, one worry that pharmacies may have with ordering buprenorphine is that because it's a controlled substance, distributors have limits and thresholds on how much can be purchased. And there are concerns about exceeding these thresholds. But be aware that DEA has stated that distributors or wholesalers should carefully examine any established purchase limits in light of the expected increase in buprenorphine prescribing. And they want to ensure that pharmacies are able to dispense legitimate prescriptions for buprenorphine for OUD without undue delay. So consider contacting your distributor if you have any problems ordering buprenorphine due to their controlled substance purchase limits. Distributors can provide info on submitting a threshold change request to start the process of getting those limits adjusted if needed. If you don't have buprenorphine in stock, offer to help patients find another pharmacy that does, and also work as a team to reduce other barriers that patients may face, such as by expediting any insurance issues. Continue to use your state's prescription drug monitoring program, or PDMP, as a tool to support appropriate dispensing, but not as the final word. We know PDMPs are valuable for monitoring prescriptions, but they should not be the sole determinant in dispensing decisions. For example, don't automatically deny prescriptions with a potential red flag, such as paying cash or living a certain distance from the pharmacy or prescriber. Instead, think of these as prompts to look into further, such as through open discussions with the prescriber or patient. And again, remember that data from the PDMP is just one part of the bigger picture, but think about other important factors too. Have an open discussion with the prescriber and patient to clarify any concerns and carefully document the discussion and outcome. Continue to rely on your clinical judgment and prioritize patient care. Another way we can help improve access to buprenorphine is by minimizing stigma and helping to clear up misconceptions about the management of opioid use disorder, since these things remain a significant barrier to treatment. So, one simple strategy we can take is using person first language when talking to or about patients getting buprenorphine for OUD. For example, we can say patient with a substance use disorder or patient with opioid use disorder instead of calling that person an addict or a drug abuser. This approach offers a more supportive and respectful environment and helps to encourage patients to seek and continue treatment. Also, educate that use of meds for OUD is not trading one addiction for another. Rather, it's a tool to help patients improve daily function. For example, like I mentioned, treatment helps reduce the risk of illicit opioid use, limit withdrawal symptoms, and reduces the risk of overdose and death. And then there are other things we can do to support these patients in recovery. So we can continue to recommend or provide rescue naloxone or nalmefene for patients taking buprenorphine. And this serves as a safety measure in case of opioid overdose, since these patients may still be at risk of a relapse. You want to educate patients and their families about how to use these medications and to also have them readily available. And also refer patients for non-drug strategies or services if needed, such as behavioral therapy to help change thought patterns and habits or to help with stress or cravings. And recommend treating any comorbidities such as anxiety or depression if needed. When patients get buprenorphine products, it's also important to promote proper administration. You might remember that in the last year or two, an FDA warning came out and labels for sublingual buprenorphine products were updated to caution about the risk of dental problems, such as cavities, abscesses, or tooth loss. So as pharmacists, we want to counsel to dissolve sublingual buprenorphine completely, take a large sip of water, and then swish and swallow. Patients should also see a dentist when starting buprenorphine and at least twice a year, and report any sensitivity, tooth pain, or other dental problems. Let's close out with a few practice pearls. So keep in mind that although buprenorphine prescriptions do not need that XDEA number anymore, buprenorphine is still a C3 controlled substance. So follow the usual policies with this med in terms of counting, storing, and dispensing. It also encourages patients to store buprenorphine in a safe or locked place. Remember to double check that you're dispensing the right dosage form and strength. For example, the generic buprenorphine naloxone sublingual tabs come in 2 strengths, but the sublingual films come in 4 strengths. So to find out more about the various buprenorphine products available and to get answers to frequently asked questions, including how to treat acute pain in patients taking buprenorphine for opioid use disorder, you can see our FAQ called Management of Opioid Use Disorder. And if you're in a practice or state where you may get involved with prescribing buprenorphine for OUD, or you just want to learn more, you can use our 8-hour MATE Act training course to learn or refresh your knowledge of the options for treating substance use disorder.
We hope you enjoyed and gained practical insights from listening to this episode. Now that you've listened, Pharmacist subscribers at our Platinum level and higher, and Pharmacy Technician subscribers can receive CE credit. Just log into your Pharmacist Letter or Pharmacy Technician's Letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we've mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites, where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% off a new subscription with code CC1025 at checkout. If this episode was helpful, Follow Clinical Capsules and leave a quick rating or review. Tell your friends. Spread the word about our show. Thanks for listening. Stay sharp, stay current, and we'll catch you next time on Clinical Capsules.